Greetings, my fellow distinguished professors. The topic of my presentation is the relationship between the inhibitory effect of calcium migration by vitamin K2 and inflammatory factors. Firstly, let's look at this large worldwide study of people who died of cardiovascular disease before the age of 65 years in 168 countries. From the perspective of epidemiology, it showed that the main cause of death due to cardiovascular disease before the age of 65 years old was vitamin K2 deficiency. These suggest that bodily amount of vitamin K and cardiovascular risk are negatively correlated. Some literatures have shown that when vitamin K2 is deficient, black calcium deposits can be formed on the walls of the blood vessels. The amount of calcium deposits on the blood vessels significantly reduces after supplementation with vitamin K2. In a rat model for arteriocalcification, large black calcium deposits are seen in images of the aorta. When vitamin K2 was supplemented from 6.5 micrograms per kilo to 104 micrograms per kilo, the amount of these black calcium depositions was significantly reduced. This indicates that vitamin K2 has an inhibitory effect on calcium deposition in vascular disease. Moreover, through qualitative detection of Gas6 expression using the Western blotting method, we found that the expression of Gas6 in the atherosclerotic models was significantly reduced compared to the control. The observations of the changes upon administration of vitamin K2 at low, medium and high doses suggest positively correlated increase of vascular Gas6 protein expression. As Gas6 is a vitamin K-dependent protein, this discovery implied negative correlation between Gas6 expression and vascular calcification. In other words, upregulation of Gas6 expression by vitamin K2 can lead to inhibition of vascular calcification. As calcium in the body is normally stored in the bone, how does it end up depositing in the blood vessels? The left diagram shows the relationship between the amount of calcium deposition and age. We found that inside the blood vessels, as we age, the blood vessels become more calcified and the severity is higher in male than in female. On the right side, this shows the relationship between bone mass and age. Initially, bone mass increases from age 0 to 36. But at the age of 36, the level peaks and the bone mass gradually decreases at the rate of 1% per year afterwards. The rate of calcium loss is much higher in female than male, especially after menopause, indicating the greater seriousness of bone health problem in female. Based on these two graphs, we propose that calcium loss from bone with age can lead to its gradual deposition on blood vessel walls, resulting in vascular calcification. In this way, leakage of calcium from the bone and thus deposition of calcium in the arteries is the reason for various illnesses. However, not much is known in relation to the arteriocalcification due to leakage of calcium from the bone. Most patients will actively and automatically take calcium and vitamin D supplements when they are deficient of calcium, such as the case of osteoporosis. However, results from many years of researches do not support the positively correlated relationship between calcium supplementation and improvement of osteoporosis. In other words, Calcium obtained from diet cannot be transferred to the bone. Calcium from external sources firstly enters the body as free calcium, but they do not bind to bones. Vitamin K2 then binds to these free calcium ions to the collagen proteins in bone, playing an essential role in bone formation. Osteocalcin is activated by vitamin K2. The mechanism behind is the gamma carboxylation of the glutamate residue at the calcium binding site of osteocalcin, resulting in the conversion into gamma carboxyl glutamate residue. This in turn activates osteocalcin and allows the combination of two negatively charged osteocalcin molecules to two positively charged free calcium ions. The gamma carboxylation reaction is catalyzed by gamma glutamyl carboxylase, which do so by transferring an additional carboxyl group to the gamma position carbon atom of the glutamyl residue of the substrate protein. Here, vitamin K2 is known to act as a cofactor for gamma glutamyl carboxylase. Vitamin K2, together with gamma glutamyl carboxylate, activates osteocalcin, preventing release of calcium from the bone to the bloodstream. Arteriocalcification is inhibited as a result. Based on these results, the relationship between vitamin K2 and the distribution of calcium in the body is clearly demonstrated. We conducted a clinical trial to evaluate the effect of continuous vitamin K2 intake on bone mineral density in osteoporosis patients for 1 year. We then evaluated the effect of vitamin K2 through bone mineral density measurement. We measured the bone mineral density of the lumbar vertebrae and femur using dual energy X-ray absorptiometry. T-scores were found to be increased considerably after vitamin K2 consumption when compared to the baseline. Data of various patients are shown here. Although there were variations among patients, it can be said for sure that the bone mineral density increased. Analysis of data from more than 2,700 study participants showed a statistically significant increase in bone mineral density, with a mean T-score of 2.91 before consumption, as compared to 1.07 after consumption. In addition, osteoporosis-related symptoms such as joint pain, activity limitation, and muscle weakness were also found to be improved because of vitamin K2 intake. These results indicate that vitamin K2 can promote the binding of calcium to osteocalcin and thereby improve bone and joint symptoms in osteoporosis patients. In order to verify the effect of vitamin K2 on bone strength, we designed a glucocorticoid-induced osteoporotic rat model. The model was created by administration of glucocorticoid for 3 months to a rat model. After that, vitamin K2 was given to the new rat models for 3 months, and the bone strength were measured. Using a tensile and compression testing machine for metal, bending tests were carried out on femurs removed from these test animals. The stress-strain curves of the bones were then plotted, as shown in the figure on the right. A comparison of the respective bone strengths was also performed. If you look at this figure, The first bar from the left shows the control, a normal rat with highest bone strength. The one next to it indicates osteoporotic model, seen with the lowest bone strength. The third, fourth, fifth bars from the left are respective groups of osteoporotic models that were given 6.5, 26, and 104 micrograms of MK7. Bone strengths of the osteoporotic models that were given 26 and 104 micrograms of vitamin K2 respectively showed increase in statistical significance. A statistically significant increase was also seen in bone strength on the positive control that were given 104 mg per kilo of MK4, a dose 1,000 times higher than MK7. Staining of bone sections revealed cavities in the bones of the osteoporotic model. The cavities were restored after treatment with vitamin K2. Wet weight, dry weight, and ash weight of the bones of these models were also measured. Basically, the intake of vitamin K2 resulted in an increase of each of these weights. Bone calcium, serum calcium, and urine calcium concentrations were also measured. Administration of vitamin K2 led to a statistically significant increase of bone calcium concentration. Low and high dose of vitamin K2 also raised the calcium concentration. On one side, a statistically significant reduction in urine calcium level was observed, suggesting the suppression of calcium loss by vitamin K2. On the other hand, serum phosphorus concentrations showed a significant decrease at medium and high doses. Urine phosphorus levels were raised significantly at low doses of vitamin K2. These results suggest that vitamin K2 regulates the balance of calcium and phosphorus in the body by inhibiting calcium release and promoting phosphorus release. In these osteoporotic models, serum alkaline phosphatase was found to be elevated, very likely due to bone destruction. But when they were given the course of vitamin K2, inhibitory effect on ALP elevation was seen. Hydroxyproline is a major component of collagen and is found in bone. High doses of vitamin K2 have been found to significantly raise hydroxyproline levels and thus increase the collagen content of bone tissue. Moreover, statistically significant increase in osteocalcium level was observed upon vitamin K2 administration. There was also an increase in bone morphogenic protein at higher doses. Furthermore, an investigation of proteins associated with bone metabolism showed vitamin K2 stimulates the biosynthesis of osteoprotegerin, calcium-binding proteins, osteopontin, and osteogenic proteins. The aging process can bring about calcium leakage from our bones and deposition of calcium in the walls of blood vessels, causing arterial calcification. Vitamin K2 can reverse these calcium leakage and return the calcium from the blood vessels into the bones, thereby reducing calcium deposition in the blood vessels. In a sense, vitamin K2 improves osteoporosis and arterial calcification, leading to the resolution of cardiovascular diseases. Other than bone metabolism markers, we also measured inflammatory markers. Firstly, high doses of vitamin K2 are found to inhibit the level of leukotrienes. We also measured thromboxane B2 level, and a statistically significant reduction was seen after vitamin K2 administration. Whereas for prostaglandin E2, a marker for anti-inflammation, administration of vitamin K2 led to a statistically significant increase. Additionally, 6-keto-prostaglandin also statistically significantly increased upon vitamin K2 consumption. Here we also measured C-reactive protein. At medium and high doses, vitamin K2 was able to result in a statistically significant increase of C-reactive protein. Last but not least, vitamin K2 showed considerable effect in suppression of ceruloplasmin. Here let's summarize the effects of vitamin K2 on inflammation. A major reason for inflammation is the cyclooxygenase pathway. Arachidonic acid that is released from the phospholipid layers of the cell membrane goes through a series of enzymatic reactions led by cyclooxygenase before being ultimately biosynthesized into a substance known as thromboxane. And the accumulation of thromboxane will promote blood clot formation, resulting in inflammation in the process. A common example of anti-inflammatory drug is aspirin. As a COX inhibitor, it inhibits the action of cyclooxygenase and reduces the production of thromboxane, leading to downstream actions including anti-inflammation and analgesic effect together with inhibition of blood clot formation. On the other hand, vitamin K2 does so with a completely different mechanism. According to our researchers, it increases the level of prostaglandin E2 and in turn promotes conversion of 6-keto-prostaglandin. By doing so, 6-keto-prostaglandin shifts the direction of the pathway and turns itself into the main downstream metabolite of the cyclooxygenase pathway, limiting the production of thromboxane, the original metabolite of this pathway. Compared to the conventional NSAIDs, vitamin K2 induces its anti-inflammatory effect through a different mechanism, affecting the migration of calcium in the process. From the results, we can see how vitamin K2 can reverse the transfer of calcium from bone to blood through promotion of binding of calcium to osteocalcin and inhibition of calcium deposition in blood vessels. These results also further suggest that vitamin K2 is involved in the regulation of calcium in the body by inhibiting the production of leukotrienes, thromboxane B2, and ceruloplasmin, and by promoting formation of prostaglandin E2, 6-keto-prostaglandin, and C-reactive protein. This is the end of my presentation. Thank you very much for your attention.